name is Dr. Paul Shaughnessy. I'm the Program Medical Director of the Blood and Stem Cell Transplant and CAR T program here at the Sarah Cannon Transplant Cellular Therapy Program at Methodist Hospital in San Antonio, Texas. Today, I'd like to review the FELIX study using obecabtagene autoleucel for relapsed refractory adult B-cell acute lymphoblastic leukemia. And I'd like to discuss the study from ASH in 2023, where we looked at the study using this autologous CAR T product, which utilizes a fast off-rate CD19 binder to reduce toxicity and improve persistence. And this is data from the phase 1/2A cohort that we'll review. The study looked at pre-B-ALL patients who had less than 20% blasts or greater than 20% blasts, and then were dosed with the Obe-Cel product. With less than 20% blasts, they received a product of 100 times 10 to the 6 CAR T cells, and then went on to a second infusion at day 10 of 310 times 10 to the 6 CAR T cells. And in the patients with bone marrow blasts greater than 20%, they received a smaller dose of 10 times 10 to the 6 CAR T cells, and then 10 days later went on to receive the 400 times 10 to the 6 CAR T cells. So the overall dose was the same in each group, but they were dosed differently based on the bulk of disease. There was 153 patients enrolled and 127 patients were actually infused. The characteristics of the patients were well represented amongst the population. A number of patients were Philadelphia chromosome positive at 28%. 44% of patients did have a prior allogeneic stem cell transplant, and patients received prior blinatumomab and prior inotuzumab as well in 42 and 31% of the patients respectively. As far as production went, the production was very good, and release parameters were met in 95% of patients, and a vein-to-vein release time was a median of 22 days. So of the 127 patients who were actually infused with the Obe-Cel, we saw 74% of patients achieve a CR or CRI. 95% of evaluated responders were MRD negative. So very good response in this group of patients. And these responses were there in all different patient characteristic types. The event-free survival in all treated patients at 12 months was 50%. And so in this group of heavily treated refractory ALL patients, a very impressive event-free survival. The persistence of response was also seen with a high expansion rate and persistence in a number of patients for many months after the infusion, which we think is related to the excellent response in these patients. When we looked at response by leukemic burden, the patients with less than 5% bone marrow blasts did have the best overall response, and it was less in those with bone marrow blasts of 5 to 75%, and in those over 75% had the lowest overall event-free survival. And then the amount of CRS or ICANS also seemed to be related to the bulk of disease. An overall CRS rate of 69% was seen, with only 2% grade 3 or greater, and 23% incidence of ICANS, with a 7% incidence of grade 3 or greater. The treatment emergent adverse events were reviewed, and really, as we expect in this group of patient populations, but as mentioned, any grade CRS was seen in 69%, and grade 3 or greater in 3%, and the ICANS in 23% overall and 7% grade 3 or greater. So overall, this product was successfully manufactured in 95% of patients. The high remission rates were independent of the leukemic burden. 50% of event-free survival estimate at 12 months, and 17% of responders did proceed on to a stem cell transplant. And there was a favorable toxicity profile in this very heavily treated patient population. At the 2024 ASCO conference, a further update of the data was looked at, and we looked at several important other outcomes, such as the impact of the CAR T cell persistency and on consolidative stem cell transplant. The patients that were treated and their characteristics, and the infusion were all as I described previously. And what they did look at separately in this data, the overall survival was very good, with a median 12-month overall survival of with a stem cell transplant of 63%, and without censoring for stem cell transplant, 61%. And so very little difference when we looked at these overall survival arms, and did not seem to show any impact of taking patients to stem cell transplant, even when they're in MRD negative remission after this CAR T treatment. So the baseline characteristics were also well described. And when we look at survival based on CAR T persistence, we did see when there was ongoing CAR T cell persistence, significantly better survival compared to the loss of CAR T persistence. And this was also reflected in the ongoing B cell aplasia as a marker of the CAR T persistence. So the conclusions from this ASCO study were that the data continue to be upheld in the effectiveness of this CAR T product on patients with relapsed refractory ALL. The overall toxicity was as described, with low incidence of grade 3 or greater CRS or ICANS. And importantly, in this update of the data, there did not seem to be an advantage to taking people onto allogeneic transplant who are MRD negative after the Obe-Cel infusion. The overall survival and disease-free survival seem to be very comparable. What is important is the persistence of the CAR T cell, which is associated with an improvement in ongoing survival of these patients, with CAR T cell persistence at 6 months showing improvement in event-free survival compared to loss of persistence at 6 months. So overall, I think the Obe-Cel CAR T product does demonstrate effectiveness in patients with relapsed refractory ALL. The toxicity profile is very favorable, with very low incidences of grade 3 or greater CRS or ICANS. There is a rapid expansion and persistence of this CAR T in many patients, and that persistence of the CAR T product is associated with increased event-free survival. And there also did not appear to be any advantage to taking these patients to allogeneic stem cell transplant when in MRD negative remission.